thanks for, I know this was a little bit of an off time for this seminar series to be on a sunny Friday afternoon, so appreciate the hardcore presence of many here to listen to Tim Kelsey. So my pleasure to introduce Tim, and he is going to be quite a different beast than we've had from the other seminar speakers. Tim has a pretty fascinating background, starting with a journalist, being an investigative journalist out of college and covering the various wars in Iraq and Afghanistan, and having a lot of impact there on reporting on things that the world needed to hear about that was going on in that part of the world at the time, and ultimately came back into the UK, where he took on various positions of growing prominence in the news space, different news publications, very high-profile ones, and ultimately turned his investigative mind to health and began exploring some of the health systems and the hospitals, and was sort of shocked to find a lot of the kind of quality metrics and how one can go about ensuring that patients are getting the best care and being well managed and so on just wasn't happening. So it was really influential in sort of turning upside down a bit those existing medical centers within the UK and causing various changes to laws and new programs and so on. And so he'll talk a bit about that, but and then most recently has taken on these director level positions for the National Health System in the UK, where he's been pushing the agenda of transparency and quality measures around the hospitals. Had founded this company, Dr. Foster, which was one of the first ever to give the kind of mortality and other health outcome statistics with respect to not just the hospitals, but even getting more granular down to the treating physician. So it wasn't the most wildly popular guy to be pointing to who was having higher mortality rates given their treatment regimens, but has had just an amazing impact and is now heading sort of as a chief information officer and technology officer for the NHS, heading all of their big data endeavors going on there, which includes the genomics, and how all that information is ultimately going to better impact the lives of patients and improve the outcomes and management of care in these facilities. And I think the U.S. can take a look at a lot of what Tim's pushing for our own thinking here as we move in similar directions. So without further ado, I welcome Tim, and it's going to be a pretty interesting talk in that Tim uses no slides. So I think one of the rare individuals who can stand up without that crutch to educate us all. So, Tim.
Thank you. Well, thank you very much, and a great privilege. And I'm really sorry that you're not out in the park in such beautiful weather. But so what I kind of wanted to discuss, as Eric was saying, was this conundrum, which is essentially how do we, as a planet really, but certainly as people in the developed world societies, how do we make sure that machine learning, developments in computational science, and the advent of molecular pathology support possibly our most important social imperative, which is, in my view at least, the sustainability of high-quality healthcare in a global society that has never known such overcrowding, inequalities, and lengthy life. It is by far the most important social conundrum we have. It's fundamental to the finances of most countries in the world. And how are we going to make science bring to bear all its potential on solving this very, very fundamental human problem? And too often, I think, as I'll discuss, science sometimes runs ahead of the public policy imperative, the ethical human dimension that makes it embed itself cleanly in social justice and social outcomes. So that's what I'm going to try and talk a little about today. But I wanted to start with a kind of quiz. So, interested in your thoughts on what do you think the average age of death was for a Japanese person in AD 0? So 2,000 years ago, what would you reckon the average age of death of a Japanese person was? Any thoughts? 65. 65. 20? 70? Okay. Normally it's like 40, 35. Okay, here the party trick is it was 14. Average age of death, 14, 2,000 years ago. What is the average age of death of a Japanese person today? Average. Yeah, 86.6. Average in 2,000 years. What is the average age of death going to be in 2050? Average. Ish, just under. No, it's 92, but this is average. This is average. So here's another little positioning. So what do you reckon the number of centenarians in Japan was in 1960? Number of those over 100 in 1960. Come on. Yeah, 133. What is the number today? 28,000. And what is going to be the number in 2055? 500,000. Yeah. Now, I learned all this in Korea because they come at this problem not from, and they come at this problem from this very simple perspective, which is they have very rapidly aging populations. I mean, these are the world's most rapidly aging populations, the Japanese and the Koreans. And the health issue for them is not obesity, diabetes, they have those issues, of course, but it's the increasing gap between chronological age and healthy lived life. And this gap is growing exponentially as we speak. And I was at a conference which was actually on happiness, I'll come back to that in a minute, in Korea, where the Japanese were essentially arguing correctly that they have the longest lived population as a matter of national pride to some extent, but much more importantly, they have they beat the Koreans on healthy lived lifespan, which they kind of do. Anyway, the Korean gentleman who came on afterwards, the professor of statistics came on afterwards, argued that they weren't using the right variables, and that in fact the Koreans had a longer. Anyway, the point is that happiness in Korea means specifically the improvement of healthy lived life for the very, very elderly. That's what happiness means. And as a result, the president of Korea has set happiness as her #1 political objective. It's the only nation on the world for which the #1 political objective, South Korea, this of course, is happiness. I'm sure they have it in North Korea too. And such is this social crisis, this impending sense of social crisis about what are they going to do with this thing that's going to break the back of their society, their economy. How are they going to keep very, very old people from not absorbing every pound of their gross domestic product? That they are quite close, I think this is probably not going to happen, but quite close to actually statutorily requiring jogging as in their older population. So jogging is I'm sure you've done this to death, but as it turns out, the jogging itself is the most effective preventative action for extending the gap or reducing the gap between chronological age and longer lived life. More than yoga or tai chi or eating better, jogging and they've done a load of research on this, as you can imagine, in their bid to try and find a way of dealing with this problem. So the basic point about all this is that this extraordinary natural phenomenon, which on one hand can be tragic, so the other side effect in Japan is the emergence of this terrible phenomenon of isolation. I don't know if you've come across it, where people live very long lives, they die on their own, their families having deceased before them, and for many months are not discovered. And this has become a sort of national shame in Japan. Tens of thousands of people each year are found in this condition. So there's a sort of social fragmentation and risk, which is already beginning to feel really very real in Japan. But on the other hand, this is an amazing human opportunity. This is an opportunity which we mustn't regard as a challenge I so often hear people talk about the public health realities of today, longer lived life is somehow a bad thing. It clearly isn't a bad thing. It's an amazing opportunity. And the question is, how can we improve healthy lifespan through better investigation of our data? And we're about to be given some new tools. You're already right at the cutting edge of developing those tools, whether that's kind of bioinformatics in relation to genomics, or whether it's the emergence of insights into the molecules, the trillion molecules in our gut that play around with each other and determine our wellness. But what we haven't done is determine properly, in a very public way, what the relationship between the machines that will tell us what we should do to maintain our healthy lifespan are and ourselves. We're about to be invited, you are already inviting yourselves to investigate your own data in order to improve your lifespan, yet we haven't properly, in my view, determined what the rules of engagement are going to be with the machines that are going to help us do that. Second question, well, third. Who in this room has heard of Frank Rosenblatt? Okay, there must be someone. I can't believe it. You can't believe it, seriously. Okay, can you all go on Wikipedia immediately after this talk and go and hunt down Frank Rosenblatt is going to turn out to be the guy whose statue appears in every small town across the world, because Frank Rosenblatt, an American, in 1957 invented the perceptron. How many people in this room have heard of the perceptron? Oh yeah, a few, thank God for that. So the perceptron was the first machine that was capable of learning. And of course it was pre-transistor, it was pre-digital, and it was like a bunch of dials. It looked a little bit like the sort of Alan Turing machine, bunch of dials and wires. But he taught this machine to learn how to distinguish between the letters of the alphabet. And even when you degraded its intelligence by putting out some of the wires, it was still able to determine the characters of the alphabet. And it was a real milestone in the development, of course, of machine learning, which is the other big fundamental phenomenon that we have to deal with. We have, on the one hand, aging, the opportunities that offers to human productivity. On the other, we have machine learning, which is a much more recent phenomenon, and arguably really only started with Frank Rosenblatt working for the US Navy, trying to develop a machine that could learn back in 1957. So today, of course, as you all know, we've moved on massively. We now have, deep neural networks. I'm not a technician or technologist, scientist at all, and I'm absolutely amazed that that there are tools you can now use to speech recognition synthesizers that allow you to go on to Skype and talk in your natural voice, for that to be translated in real time into Chinese in your natural voice. I mean, so machine learning has now developed to a point where we're beginning to see it properly understand movement, speech. We are at the advent, not of kind of machines being humans, and I think the jury's somewhere between 80 years and 1,000 years for that to actually happen. But we're at the point where weak artificial intelligence, or this kind of machine learning, is for real now and will be fundamental to the challenge I mentioned before of helping us live longer, live lives. The third thing that I just wanted to bring into the conversation is another kind of machine. And I don't know how familiar you are with these machines, but these are the new machines that are capable of, at scale, diagnostics of the molecules in our guts. The new generation of molecular pathology machines. They're very rare. They are very large. The reason we know about them in England is by a very happy accident of history, which is that one of the big legacies of our Olympic Games back in 2012 was that Glaxo built these incredibly advanced machines for molecular diagnostics in order to evaluate banned substances in athletes. And so we repurposed those machines to start doing a much more clinical kind of investigation into what does molecular pathology mean in practice. We have 2 of them. They're phenomenally expensive, and they sit currently in Imperial College. And I was just saying to Eric earlier, I don't know if you'll know this, but I guess most scientists had originally thought that human urine was a relatively simple liquid. Anyway, it turns out now that we've got these machines that it's comprised of 10,000 molecules, far more sophisticated than we thought, of which only 2,000 were known to modern chemistry. So each week they're churning out a kind of new molecule from this machine. And the volume of data they're producing in this incredibly basic molecular analysis, if you think about the future as it will become, is similar per day to that of the Hadron Collider when it was running. So we're talking about massive volumes of data being produced in some of the most simple but advanced molecular analysis. And you guys here know Moore's law. You can just see where you go from giant machines to laptop computers doing the same job at much higher volume very quickly. So I think we're going to see a kind of coming together of these molecular machines with machines that can tell us what in the hell it all means, with us and our aging problem. And I think that's going to become mainstream to clinical practice over the next 5 to 8 years. And this is where we have our problem. It's going to happen much quicker than governments around the world, policymakers around the world are recognizing. So I'm just going to park that for a minute and come back to it in a second. So let me tell you about the NHS. So the National Health Service spends about £100 billion a year on buying healthcare across England. If it was a country, it would be bigger than Argentina or Poland. It's GDP by GDP. And obviously, and crucially, it's universal healthcare. So everybody in our country is able to access health services of all descriptions without without paying for it. And a few times ago when I was here, I don't know, a couple of years ago, I was giving a talk here actually in New York, and I was on a panel with a TV show host and another extraordinarily right-wing member of your political establishment, who were who were openly accusing me of being a communist. And I said, so, you know, if the price of being proud of having a universal healthcare system which looks after everybody, then, and that means I get to be called a communist, then I'm a communist. So I just want to make it clear, I really believe in this concept, and I believe fundamentally that health is about social justice and that we can't leave anybody behind. And for those who don't know this, actually, the reason the National Health Service was founded in 1948, in a way, is this kind of post-war contract with all those returning soldiers, with the families who'd sacrificed so much, was we'd been through one infernal experience of fear in relation to the possibility of losing that war and the sacrifice that went with it, to be replaced by another which was almost more insidious, the fear that you could not afford to pay for health when you were in an emergency. And our society, it was a very specific decision, essentially decided to rule that out any longer and set up a national health service that meant nobody was going to live in fear of not being able to afford healthcare. So we now have this massive problem because we're running out of money, as you are, but we're running out of money and we're talking about it because we care about the values of our healthcare system. So we recently published, last October, for the first time, a kind of vision for how we were going to ensure the future of our healthcare system. And we openly admitted that in 5 years' time, we're going to have about £30 billion, we're going to be about £30 billion adrift of being able to afford to pay for people's care. Just rising demographics, rising cost of care, and so on. So we're now engaged in a big plan called the 5-Year Forward View, which, again, please have a look at online. It's actually a wonderfully short document for government documents, 28 pages, well written. I wrote the first line and other bits of it. But it's really short and to the point. And what it says is that we think we can continue with a sustainable healthcare system if we take advantage of these new technologies I've just described, if we future-proof ourselves positively to make sure we can offer personalised medicine to our society at scale. And we do take advantage of genomics, come back to that in a second. But also that we have to find new ways of working. We have to find whole new models of care in order to reduce cost and improve quality. Alongside that, the Prime Minister challenged the National Health Service a couple of years ago to be the first in the world to sequence 100,000 whole genomes. I guess people will be aware of that. And this was really to try and force the pace of us understanding what the operational implications of this new emerging opportunity for supporting longer-lived, productive life in our society. And I happen to run that programme for the NHS in partnership with something called Genomics England. And I was saying to Eric that I think much of the work you're doing here is incredibly important to helping us try and get to this point by 2017 when we have not only sequenced those genomes but actually made clinical sense of them. And I think there are some big challenges, and there are definitely no guarantees that that'll deliver what we hope it'll deliver. But I think what we all do believe is that by 2020, come what may, genomics, molecular diagnostics will start to have become mainstream. And this will be a big data revolution that we've never seen before in any other part of our society. You know, we talked a little bit, maybe we've seen it in meteorology, but I tell you, this is going to be fundamentally different. And my belief and prediction is that by 2025 in the NHS, you will be born, you'll be given a blood test, you'll be given a mobile phone, and you'll be told to go on and manage your lifestyle conditions. And we will enter a data relationship, a very personal database relationship with our patients, which is how we can continue to afford healthcare. So essentially what I'm really trying to say is I think now is the moment that we have to launch bravely a very big new conversation with the public, and I think you at the cutting edge of the science need to be absolutely out there on the front foot, which is asking for some really big questions about the new governance that we need to protect public confidence in this science. So what you know, the speed of the developments and the absence of that conversation is worrying me. This is a much bigger social revolution than cloning or stem cell research. Those things are important, but they only affect a relatively small number of people. This potentially is about lifespan. This potentially is about how societies compete economically. It's about the productivity of of people. So that's what I wanted to dwell on. And my belief is that the answer to the challenge of governance in a world in which the machine becomes our doctor, we will want to know how that doctor is making their decisions. In our country, as here, we have, you know, occasional terrible human tragedies in which doctors either maliciously or inadvertently, you know, kill, harm their patients. And it turns out that healthcare is by far the most dangerous industry on the planet. Broadly in England, about 20,000 people lose their lives avoidably just because they get treated by the NHS each year. And I think in the US, the similar figure is nearer 80,000 people. These are common statistics across all healthcare systems. Healthcare is fundamentally unsafe. It is dangerous. So we have to do everything we can to make sure that we maximize its transparency to its patients and its doctors as the first safeguard for improved quality. And this will be even more important in the age of the machine that we're talking about. So transparency I just want to dwell on, because transparency, I think, is the answer to this public policy question. And it's going to involve a real degree of bravery, both amongst those who are developing the new sciences and those who are providing healthcare. This is about being open about things that work and don't work. It's about being open about IP. We're going to have to abolish some old lingering concepts of intellectual property ownership. They will not work in a world which has to be transparent about the nature of algorithms that are making important clinical decisions. We should perhaps discuss that. And transparency, we already kind of know works. So I just want to quickly tell you a story about how I got into this in the first place, because it was in a way the early days of the transparency argument. As Eric said, I was, at this time, this is 1999, I was news editor at the Sunday Times, which is one of our big newspapers. And I got a phone call from my mother. It was a Friday night, you know, deadlines looming. I was in a pretty stressed out state. My mother rang in tears. Now, my mother's a GP, a primary care physician in the southwest of England, and was a specialist in breast cancer. And she rang me saying she thought that the local radiological consultant in the local hospital was killing his patients. And I paused, drew breath, and said, "You're not proposing to become a whistleblower, are you, Mum? I mean, you can't be. You know, 55, I'd spent my career then, up to that point, as an investigative journalist. Nothing good happens to whistleblowers. However good the public service they perform, it is a horrible emotional experience, catastrophic in many cases." And I didn't quite know what to advise her, but I said I'd ring her back. By the time I rang her back, she had very bravely made the decision to blow the whistle, and the subsequent investigation revealed that this guy, who was an alcoholic, had been receiving referrals, mammograms, from referring physicians, and quite literally sticking them down the back of his radiator in his office and completely ignoring them. It turned out he hadn't seen a patient for 3 months. And the inquiry concluded that at least 11 women had had their lives foreshortened through this very malicious negligence, and as many potentially as 50. And obviously that hits you hard, and particularly when it's your mum. But the idea that we could be in a situation which is today, right now, right across the US, UK, of situations of that sort occurring without anybody knowing, even though the data exists with which to have identified them, is a terrifying and a real social problem. So I actually left my job because I just couldn't believe we had a healthcare system that was flying so blind, to set up this company, Dr. Foster, which was really a campaign to promote arguments about transparency of healthcare, principally to support patient outcomes and reduce harm. But also, I began to argue, because it created a different kind of competition between doctors and nurses to improve their performance. It was a kind of honourable competition. And as Eric says, it wasn't at all popular. In fact, the first year into Dr. Foster, I was openly accused by one of our eminent Royal College presidents of being a member of Al-Qaeda for visiting terrorism on the healthcare profession. Anyway, this kind of transparency, which is really just first stage transparency, and something we can learn from when we come to think about what kind of transparency, what rules do we need to have for the machines, the machine generation. But in our current analog sort of world, where it's people that are largely making decisions and causing harm, it's simpler, but the rules are kind of the same, and it is about being open about things that work and don't work, and putting the data out there, not just for you to do the analysis with, but to make sure that data is presented in machine-readable format so that everyone else can do the analysis and test you and ensure you're not making things look better than they are just through the nature of your risk adjustments. So we now in the NHS take this very seriously, and if you have the time, you might want to go to a website called www.nhs.uk nhs.uk/mynhs. And what you'll find there, this is something I've been quite focused on with our Secretary of State for Health, is publication of scorecards, comparative scorecards for pretty much every NHS provider, including mortality outcomes for individual surgeons, unit-level data, which is beginning to start generating a really deep and profound conversation about how do you measure quality in healthcare, and when we do know, when the metrics work, like, say, mortality in cardiac surgery, just do we have a problem with underperformance, how can we solve it? It's working to improve quality in the NHS. And equally, the absence of transparency, the absence not just at one end causing the kind of tragedy my mother reported, but on a day-to-day basis, I'm sure you're familiar with this, just on a routine, grinding basis, adding an administrative burden to the clinical workload, which is just a devastating indictment, or which is a deeply unproductive way of supporting clinicians actually work with patients. Now, in this hospital group, you have a very advanced state of digital engagement internally. But if you could just imagine, most of our hospitals in the NHS, and many of the hospitals before meaningful use was introduced by the Obama administration here, were fully paper-based. In fact, the NHS, I think, remains the largest global consumer of fax machines. We largely hold our patients together with bits of string, treasury tags. I don't know if you know them, those little bits of string with plastic ends on them that hold files together. That is the instrument, that is the difference between secure identification of patients and bad things happening. So we have to solve this problem, not just because of harm and quality, because actually it gets in the way of good clinical progress. And equally, we need to start, as we are doing, to give patients transparency of their own data, because the other precondition for making sense of the arrival of personalised medicine is not only we can see whether or not it's causing harm and whether or not services are harmful, whether it's man or machine, but equally we want people to be able to take much more control for themselves of their healthcare. So I'm very proud to tell you that the thing I partly did this job to do has now been achieved, which was to enable every citizen in England to be able to access their online medical record, to be able to book online appointments and order online repeat prescriptions in general practice across the board. We now have 98% of the NHS capable of offering that service, and we're about to start advertising it to the public. And my belief is, and open APIs on top of all those services so that the innovation enterprise community can come in and start developing the kind of services and products which will bring those opportunities to life. And my honest view is that just like in one sense Facebook, but in another online retail financial services or travel, the transparency of our own data, so important later with genomics and personalised medicine, but even at this level, just of your own medical record, will transform people's interest and responsibility for their own health and well-being. And as we know, I don't know what the figures are here precisely, but in England, 1 in 10 school children under the age of 11 is obese or overweight. Their parents have no way of dealing with that, really. Offering them digital solutions based on up-to-date clinical records, I think, will be a tool that will help with lifestyle management and hopefully deal with some aspects of that problem. So kind of beginning to turn the NHS into an open digital infrastructure, promoting a social movement where we bring in developers, entrepreneurs, for-profit partners to start working with us on developing the tools, the wearable devices, the data feeds that will improve clinical practice, I think will help improve quality, drive down cost, and also will lay the foundations for personalised medicine, because without that kind of digital infrastructure, we will not be able to provide the sort of phenotypic elements that are so necessary in the analysis of genes and other internal molecules. So in a way, just bring us to an end, the challenge then is, how do we make this transparency work? What are the public policy questions we need to be working through now in public, in a big public conversation, to ensure that we work out the conundrums of machine learning, the differences people will have in considering the fallibility of human doctors, which is bad enough, and against the fallibility of machine doctors. I mean, how tolerant will we be? Will we be as tolerant of a failure to make the right diagnosis in our machine doctors as we will in our human doctors? I don't know the answer, but we need to start reflecting on these questions quite quickly. And if we are to have full transparency, does that mean we don't have IP at all? Does that mean we do what I think you're doing here, which you've got these dream competitions? Do we have kind of machine contests in public, which might preserve a degree of value for the entrepreneur and the in the black box algorithm. But I just personally don't see how it's possible, though. Well, we need to work that one through. What's the new economics of this science? Why will private capital invest in a world where there may be a risk to return because of the ethical and public requirement for accountability of decision-making? So truth is that no one really knows the answer to these questions, and that we just need to start making progress on asking them. So finally, I think if we don't do this quite quickly, and you are in a most, as I've learned this morning, a most unique, I think, global position to start helping countries, health systems around the world ask these questions. And starting here, I think this is such an important place to begin. If we don't, I think the public response to that first moment where a machine makes the wrong decision or condemns somebody to a life of fear and risk because they've given them the wrong risk profile around their genomic predispositions, I don't know, but it'll be catastrophic if we haven't started this big public policy debate. And I do believe that transparency will come to be regarded as the most important public policy contribution of our generation, more than the science you are currently investing such great time in. So we have to take our society on a journey. And at the moment, I think most of us are very, very far behind where you are now. And we need to find a way in which we can come together around solving this extraordinary human opportunity of longer, healthy lived life. Thank you very much.
All right, so thank you, Tim, for that talk. So now we'll, a lot being thrown down at you regarding the future of medicine and what it's going to take to sort of catch and ride that wave without it being catastrophic. So why don't we take some questions for Tim? So start a dialogue. Anybody want to
I've got one.
kick us off? Jason?
Hey, Tim, could you, that was a great talk.
Thank you.
I mean, the NHS, I think, is also in such a unique position as being really on the front edge with Genomics England and having, you know, a national healthcare system where you have access to very large population data. Can you talk about what the current public engagement is and sort of public opinion about access to personal medical records?
Yeah. So privacy is the other, I didn't really mention it, but transparency is the only real antidote to privacy, the problems of privacy too. So what we've learned, we had a bit of a car crash last year, which some of you may have noticed, in which I launched a program to do something really simple, which is to just link nationally, at patient level, episode level, data in general practice with data in hospitals. We have good data in hospitals, but we have very poor data, very poor linked files, which means we can't support improvements in things like early diagnosis of cancer because we don't know which GPs are not diagnosing early, we don't understand the behaviors, and we know we can improve outcomes very quickly if we can just link these data files and follow the patient across more of a pathway. And we need it nationally because we need to be able to benchmark and compare across different demographic circumstances across our country. And this hit the wall in last February, and I was on television back-to-back being, you know, properly humiliated because there are a number of things that we hadn't done. We weren't being clear about who would get access to this data, and people wanted much more transparency. The newspapers have, I think, articulated legitimately a public concern about, like, we want the healthcare system to have it, but we don't want the insurance industry to have it. We don't want the junk mail industry to have it, and we absolutely do not want other government departments to have it. So we hadn't laid down safeguards that said that cannot happen. We also, because we can't guarantee, it's a really important point this, particularly when you get to the kind of advanced data analysis you're doing, you cannot guarantee the safety of that data. So there's no point in pretending you can, you can't. And maybe it's not cybersecurity, but there is just no way in a digital age that you can 100% guarantee the safety of somebody's data. So in order to provide, we decided, and I think it's quite a brave policy decision, because we collectively could not guarantee it, though we were taking every step. We have like defense-grade security on NHS systems, but still you can't guarantee it perfectly. We decided we would give people an opt-out, a legal opt-out, to decide whether they wanted their data shared for purposes other than direct care. And we, last year, didn't explain that terribly well. It's a new right. It was confusing. So I suspended the program last year, and actually we're about to start testing now the program, having redesigned everything about it, put in place new laws to provide adequate safeguards, responded, I hope, very positively to the challenge around privacy, transparency of uses, and so on and so forth. And we will now test the degree to which the public feels reassured, in which their clinical advocates, GPs, also feel that they're in a position to easily explain what this opt-out means to people. But societies at large are going to have to deal with the balance between and the honesty about the fact that we can't guarantee safety of data with the reality this is people's data. This is not the state's data. So you have to respect their rights to make decisions about its use. Now, of course, if you're a scientist or a researcher, this is a very difficult dilemma because you want the data. What right do people have to opt out of health data? That is going to, if they do it at scale, that's going to compromise your ability to plan services and that's kind of, so in the end it comes down to arguing the benefits case and so on. But these are the central conundrums which we in the NHS are trying to work through, and I hope we can be successful enough to help other health systems on their journey, because there is, to my mind, no option than we respect, as Tim Berners-Lee would say, that this is my data. But on the other hand, we've got to try and help you understand why contributing that to the sum of our insight into healthcare is such an important social responsibility. So that's just one of the things we're going to have to help people with.
Okay, Rad?
Thanks, Eric. Thank you for a lovely talk and overview. Specifically to the point where you put us forward in, let's say, 2025, I have a three-part question.
Yeah.
Have you done any cost analysis in terms of wide increase or sustainability? That would be the first part. Second is there any benefit of having global initiative in terms of collaborating outside of UK, such as, I don't know, with US and other countries, to have a large think tank to approach it? And the third is, what is your opinion in terms of roles of for-profit, non-profit, and government as usual suspects that contribute to achieving these goals?
Crumbs, those are massive questions. So the reason we're doing the 100,000 Genomes project and we are investing in these molecular pathology machines is because, and we're being very upfront about the economic challenge that the health service faces, is because we need to cost the investment we need to make. We need to decide when do we invest in this emerging molecular science and molecular pathology, and how much are we going to invest. So actually, we're doing that piece of work right now because we've just elected a new government, as you'll know, and the first spending review, where they'll determine what the shape of the spending looks like over the next 5 years, is going to be later this year. So we need to feed into that a credible view as to what level of investment we're going to have to make now, so that in 5 years' time we can offer personalized medicine to the public. And one of the big challenges I kind of didn't quite mention, one of the things I worry about most in policymakers, the community of thought leaders in science, in not addressing these things now, is that if we allow personalized medicine, whatever happens will happen. So, it'll happen. If we allow personalized medicine to be an offer that only the rich can afford, and when I say the rich, it's not like it is now. So only the super rich can buy those extra years. They're more expensive today because they're going to have to go and buy, expensive drugs in trial, et cetera, which they can do, which public sector services can't afford. But this new science is already, the diagnostics are collapsing in cost. So it's going to be a few $100s, which will mean that kind of a lot of people will be able to afford it, even if their public sector doesn't offer it. But equally, a large number of already dispossessed, disenfranchised people will not be able to afford it. And what you'll find is that the cost of longer life will fall per year, but the number of people for whom access is enabled will also fall. So you'll end up with a lot of people living, the gulf in age, growing really quite substantially. And I think this could have devastating consequences for society. So one of the reasons why I'm sort of promoting this message and trying to encourage policymakers, one of the reasons I'm here actually is next week we're having a big conversation with the HHS about some of these things, is because if we don't collectively, across the globe, frankly, start working out how we do ensure that social justice operates in the context of personalized medicine, I think we'll have a very, very a disastrous social moment, social legacy. For me, I don't believe that governments have the capability to be the white knights of our machine doctors. So I don't really, at the moment, I'm not quite sure what the solution is, which I was so interested to hear about your dream competition. Because, you know, if the private, I mean, I presume it's largely going to be the private sector that owns the algorithms, I guess. I mean, maybe some not-for-profits as well. So how do we open up the black boxes in a way that satisfies public need for accountability of the quality of their decision-making? And I just don't see government having the capability to do that. So I don't know who those white knights are or who is running the machine, the dream competitions. I don't actually know, but that's the kind of question we need to figure out. It might, you know.
And it's worth noting that, you know, on the, you know, the dream competitions are a pretty good example. So you'd mentioned earlier about whether, you know, sort of IP and turning the lights on the algorithms and so on. You know, the dream competitions, which are massively popular, which engage, you know, some of the best modeling groups in the country and around the world, you know, everything has to be completely open for that. There can be no black boxes. The code has to be there. The workflows have to be there. It has to be reproducible. And so what we're seeing is a movement where, you know, those things aren't really being protected, even from the top groups who, you know, would otherwise like to protect IP around those algorithms. So I'm actually pretty optimistic that at least what we're seeing through these competitions, that sort of open air of getting to the best model or the best ensemble of models will be effective.
Yeah.
And then he sort of had the last one, which I'm kind of interested in too, the middle one on collaborative opportunities. Like, what's the view from your massive sort of set of data, that population, and collaborating with, you know, say an institution like Mount Sinai for, you know, better engaging the data, the patients, the algorithms. Like, what's the vision that you have for the collaborative across countries?
Well, so I think that the kind of the skills and the capabilities in all aspects of this, whether it's like incredibly sophisticated visualization or public policy development just across the piece, are so the pool of those skills is a global one. It's not a national. I mean, we don't have a full suite of capability to answer the questions we need to answer. So the only option, I think, is for a very different kind of global collaboration. And we've already started that actually with GovLab at NYU, where the NHS has commissioned it to do some work on building an expert network where we can start pulling in expertise from different parts, particularly US, UK, you know, expertise. And I think one of the things I'd really like to work with Mount Sinai on is just how we can both speed up our own insights into things like the interpretation of genomes and their clinical relevance with what you're doing. But also, I think there's a broader issue about kind of creating a what's the right word? A kind of a collaborative. I think that maybe is the right word, where people can draw on you know, global leaders in particular specialist areas to help make sure that we are not, you know, we're just speeding up the process of getting to the right public solutions.
Great. Michael?
Yeah, so this is really fascinating. So I wanted to ask you, sort of in the sense of people have modeled how you close that, for you, £30 billion gap. So it seemed like there were sort of two broad types of technology. We're talking about one that was whole new knowledge, whole new clinical knowledge that didn't yet exist. But then there was also about how to do the things that we already know to do, but just to actually get it done. So there's sort of an execution component. And I was curious if you had a sense, if we did all the things that we know to do now perfectly, so no mammograms went behind radiators, and you know, the fax machine was readable, and all the things that we already know how to do, how much of that £30 billion gap would that close? Would it close not very much, half, all? Does that make sense as a question?
Yeah. So that's the $64,000 question, and so we've had a first go, and we're going to do a lot more work on validating this, because the risk of technology is just in this sense is an enabler. You know, to engage in productivity on that sort of scale, you're looking at workforce reconfiguration, whole new models of care. You're looking at some pretty basic things like capping temporary staff costs and that kind of stuff. But in terms of the technology contribution, the piece of work we've just done, looking at what I would call just getting the basics right, you could use jargon and call it supply-side automation, demand activation, could be worth as much as maybe a third of that 30 billion per annum. So we're looking at possibly somewhere around 10, maybe And the range is quite big. We haven't done enough work on it yet, but it's a very, very substantial contributor to the opportunities for, I mean, you know, one example which I learned about the other day, and this is anecdotal, so if anyone in the NHS is watching this live stream, this is anecdotal, is that, you know, we have hospitals who fully, of course, recognize the importance of barcoding patients through the pathway of care. You know, you get your wristband, you get your barcode on it, but they haven't bothered to buy the barcoding readers. So printing off a barcode is like one thing, having the barcoding reader is another. And actually, you're not really contributing that much to the efficiency of that person's treatment by just having a printed wristband. And so just going the extra step. So we have some, I'd be interested to know in the US just how many are in the same situation. But it would be, so getting the basics right is absolutely the first objective. And so interoperability. So that's a big challenge for you here as well. So one of the great achievements of Obamacare so far has been meaningful use. But it's also not quite delivered on some of the stuff it was hoped to deliver on, like interoperability. So, you know, we know that one of the most important ways of driving effective, high-quality care is to be able to follow the patient in real time across, you know, the urgent emergency care pathway through to community services, from discharge, etc. Well, not very many healthcare systems here can do that, and we've said that we will deliver that across the NHS by 2020. So we have a lot of work to do, but getting the basics right, we think, will be a substantial contributor to that deficit. Yeah.
Thanks. Boris? We'll go next.
Yeah.
Okay, why don't this side's been waiting patiently, so why don't let's get the mic first.
A fundamental question. What is the purpose of a longer life in the first place? Yes, it's true. I mean, you may laugh, but first of all, it'll create incredible socioeconomic problems around the world. There's almost too much people in the world today as it is. And what you're saying is that you want everybody to live to be over 100 or something along those lines. One is the quality of that life, and two, what happens to all the problems it creates around the world. I don't understand the purpose of it.
So you could shut yourselves down and stop doing personal risk stratification as an objective. Well, I mean, that's a fundamental question, and I hope it'll be part of the debate about so there's a thing about just having longer chronological life, and we can argue about the whys and wherefores, whether that's a good thing, but I mean, the work you're doing here will extend human life, so there's a question about whether we should be investing in this at all, but if we are going to invest in it, what society has to do is, if we're going to have longer chronological age, is minimize the gap between healthy, high-quality life and that age as a minimum. So that's an imperative which is obvious if you're going to just decide in the first place to extend the age that humans live to. I think society needs to have that conversation. You can see careers dealing with it by going upwards. You know, the buildings are just getting taller, and I think the same is true in quite a lot of the Far East. I don't have a good answer to that question. I mean, I think I approach it positively and say that this has got to be an opportunity, but we have to work through the implications of more people in an already overcrowded world.
You're going to create a population that's much larger than we have today. It just doesn't make any sense.
Yeah.
Well, we'll all be eating stem cell hamburgers pretty soon, so maybe it will. You know, and I have to think back to, you know, when I was a kid, we used to, you know, reading some of the science fiction books, it was all sort of adopting Tim's thing of a more positive outlook, like we'll figure it out, we'll have the social conversation, we'll figure out how to do it. And, you know, the books I used to read when I was a kid were all, you know, they're sort of positive. We're going to explore the galaxies, we're going to find new things, we're going to, you know, take things to the next level. And we seem to be, I don't know, mired in this era in this sort of negative stance about, you know, those books aren't so positive anymore, and what that all means. And hopefully it does drive the right kind of discussion. But I think, you know, you have to know that as we're facing, you know, catastrophic cost for caring like Alzheimer's, and whatever the prediction is in 10, 15, 20 years, that it will be consuming all of the current Medicare budget will go to helping treating people with Alzheimer's. Like, we've got to solve that problem. And if one of the consequences is people live slightly longer, 10, 20 years longer, but they're healthier and less of a healthcare burden, like, I don't know, maybe those numbers work out. But it's a good point.
It's a very important question.
Yeah. Boris.
Yeah, I actually wanted to ask a similar question, not exactly, but I would like to maybe to specify it a little bit. What is the amount of money you think would be saved or earned if retirement time would be increased for 1 year?
Yeah.
This is a very important question. And simultaneously, how much money would you need to spend if death time also would be increased for 1 year? If there is a gap, then it worth to, and gap in the money you would earn, then this money can be used to increase the life latitude. And actually, there is somewhere the equilibrium. So we work more and more and invest money in science. The time of retirement increases. Also, possibly it will be very close to the death time, or the death time will increase. So do you have particular numbers which we can discuss? It would be very interesting.
Yeah, I actually don't have particular numbers, but we can already see how countries around the world, England included, are raising the age at which of retirement in order to release pressure on public finances. It has an enormous impact. And I was just going to say, actually, one thing I didn't say, which I should have said, is that another prediction, not by me actually, but by my great colleague Bruce Keir, who's the medical director of the NHS, is that the arrival of genomic medicine or personalized medicine and the associated insight into predisposition it'll bring for some people will mean that insurance-based healthcare systems become unviable. And so another cost pressure we need to think about, another conversation that you in the US will have to have quite earnestly, is if we can't run insurance-based systems because it's impossible to think of premiums when you know risk, and we therefore have to turn to universal healthcare because that's the only other option, and then we can calculate what the costs of that look like. And if you move to away from a fee-for-service system and to a capitation or a by-head system, a by-person system, which is what we have in the NHS, you can start to, you will probably have to fund that by increasing the retirement age of the population. So oddly enough, longer-lived lifespan, just making this up on the spur of the moment, could be the economic engine for the provision of universal healthcare because insurance-based systems can no longer work in an age of personalized medicine. So that might actually be how we afford a better level of social justice in relation to healthcare provision.
Yeah, it would be interesting to hear numbers. But
thanks
for your question.
Paul Krugman had a thing in the paper this morning, in the New York Times this morning, and so I'm curious about whether the U.S. and the UK differ in this. So his argument was that this
Just do the microphone because people are...
raising the retirement age is sort of a fallacy. It only works that for individuals at the lower end of the economic spectrum, they're not living that much longer. Their lifespans are not, have not taken as much advantage of, improvements in care, access to care, all of that, and that this thinking about raising the retirement age will disproportionately disenfranchise them. Because it will just smush their length of life. So in the NHS, where theoretically everyone has equal access to healthcare, are there still those disparities? I would assume there probably are.
Oh, yeah.
Right. And so,
how
do you deal with the we rarely hear people talk about social justice, I think, in sort of our science setting. So it's really wonderful to hear you talk about that, because everyone, from my perspective, is not naturally endowed with the same capacities. And as a human being, I think I have empathy for that, but don't know how to fix the system. And certainly it's not something that's discussed in this country as acceptable at all. So what's the situation in the NHS?
So I think this is really important. So, of course, the bottom line is you have to be able to afford healthcare, and this is therefore about productivity, but you have to at the same time recognize there are two other really important gaps which have to be prioritized as you are looking to save money and drive a more productive health service or a more efficient health service. One of them is the prevention gap. So we have a very serious problem in the UK, as every country does, with inequalities, and those inequalities are largely related to health inequality. I was mentioning earlier that if you go east along the Central Line, one of our tube lines in London, as you leave Central London, life expectancy falls by each stop by 1 year. So we've got and this is a disparity and a social injustice, which is not only intolerable in a 21st century society, but also contributes to ineffective, inefficiency, unproductive healthcare. So combining a focus on prevention and inequalities with efficiency actually works really well. And as a result, you are drawn very, very directly to some of the really big challenges where we have most inequality, diabetes, obesity, some of those kind of core challenges. So there's a big focus in the NHS on that area as a kind of root cause or a root symptom of some of the inequality. The other gap that has to be managed together is the quality gap in care delivery. So again, we have significant variations in mortality outcomes between different hospitals when risk adjusted for all the factors outside a doctor's control. So just because you walk into one hospital as opposed to another can triple your risk of death. And that's an inequality which is very expensive. So again, upping everybody's game, this is kind of Atul Gawande territory, upping everyone's game and reducing the gap is, again, a driver of efficiency. So you can look at this, it's a burning platform, but on the other hand, it's an opportunity to do social good, to improve the quality of healthcare and reduce its cost.
Okay, so Zhirong, before you go, there's another.
Sure.
Thank you so much. Just a quick question about like population versus time expansion in terms of Moore's law, because that's something that's puzzled me for a while. Do you think that it might not be purely exponential, but more of a modified exponential sinusoidal model?
What?
The question is really, in the way that we're attacking healthcare, is it that the places where populations are booming is also receiving the worst healthcare? And I think that's a universal fact. And how can we expand healthcare? I've had the privilege of being a New Yorker, so I have the best healthcare in the world. But like, how can we kind of expand that to other places?
Yeah, so it's a really complex. I think it's a really complex question. It's a very complex answer, which is, if you look at the ways in which, so some developing world, for example, societies who are, as you say, facing very substantial population growth, are actually driving very, very high quality healthcare because they just skipped the legacy of the 19th century. So they just skipped it. So they've gone straight to mobile phones. They've gone straight to mobile technologies. India, for example, is in many parts managing an extraordinarily high quality healthcare system that is taking taking all the advantage you would hope and expect from emerging mobile technologies in a way that old world healthcare systems like ours, frankly, find much tougher to deal with. They challenge conventions of clinical practice, blah, blah, blah. But in some ways, there is an advantage in less developed world countries where they can just go straight to new technologies. There is less embedded, entrenched resistance. And in fact, there's some incredible examples of, like, there's a health system in Bangalore that is doing, has developed a whole new model of surgical intervention where they've reduced the cost of hip replacements from what it costs in the UK, I don't know, £25 or £100 to like much less, by a third, 2/3. So I'm not sure that necessarily works. I think that there are some reasons for being quite balanced in assessing how high quality healthcare can spread and what it means in practice. And I just think that these low cost technologies are enabling very rapid high quality healthcare to disseminate in many parts of the third world, developing world.
So there are probably sort of dimensions that benefit well from Moore's law in the technology expansion space. I think you're mentioning some, but probably others where it's going to be much harder, like open heart surgery or these way more sophisticated procedures that still require really sophisticated machines, like very, very expensive machines that maybe aren't going to fall fast enough to make that care equitable enough over the fastest expanding places around the globe. Like maybe it is some of the technologies will benefit, and the low cost is being driven by Moore's law, but others maybe aren't moving as fast, and it is going to be still an issue. Like, we're not going to be doing robotic surgery probably anytime soon across parts of Africa and so on, right? Because instituting that technology, the cost is still really high. It's falling, but it's not falling at a pace of the the fetal monitoring equipment that you can do for $10, $20, $50. Doesn't compare to something that's going to cost in the hundreds of thousands of dollars.
But if you look at the cost drivers, though, of healthcare, the cost drivers are all about chronic long-term conditions. Yeah. They're not really about acute interventions. So if you look at South Africa, what's driving costs in South African healthcare is TB, it's HIV. Mm. These are long-term lived, and so it's about getting the whole person into a lifestyle. I mean, essentially, inequalities and costs in healthcare are largely dealt with not through applications of technology at the moment of intervention, but applications of technology in order to support prevention and lifestyle management. That's where the greatest cost improvement.
So that's a great point. Yeah, as that technology drives down, we are doing more prevention, and people aren't getting as sick. Yeah. Cool.
So I have a question regarding the cost management. So my understanding is that actually a very small proportion of people are actually consuming a large fraction of the healthcare cost. So of course we cannot eliminate those existing living people, but there's an option given current big data and the knowledge of how gene functions. The one option is basically you can tell or predict whether if a couple have a baby, how likely they're going to have, those babies are going to be healthy or not healthy, or they're going to be a big cost to the total healthcare system. Say, if that technology is pretty mature, do you think, because government is going to pay this, will government try to use this technology to manage its cost by considering, say, we prevent this couple to have babies because they have a high chance of having a unhealthy baby, which will cost a lot to the health system. So just want to get your personal opinion.
Or even maybe more realistic would be, do they have to undergo IVF procedures that, you screen the embryos that get implanted to ensure that they're going to be more healthy?
Yeah, I think so. The other context for this whole debate, when it starts to properly happen, is going to be eugenics. Is going to be, Hitler. Societies have long memories, and the last time we really thought hard about genetics as a world was during the 1940s, and in my view, as a sort of. So I think that we don't quite know what that conversation will look like, but I'm pretty certain that certainly the British society will be very, very concerned indeed that whilst we close the gap between long chronological age and healthy lifespan, what we do not do is start imposing eugenic-type solutions on society at large. I mean, we do need to have that conversation. We need to get it on the table and decide that that's not something we're going to do. And I'm sure but essentially my belief is, and I've studied the economics of this quite intensely, is that we can make healthcare affordable through the improvement of case management for individuals by giving them the tools and technologies they need to look after themselves and manage their consumption of expensive health resources for a good long while to come. And I believe we will be able to hand over sustainable universal healthcare to our children very affordably if we can just bring people into much more engagement with their own health and well-being.
But it may not start as a government imposing so much as a government incenting those to have such procedures of screening, and it could be creating disparities, right? So it may not be the government imposing that you have to have such a procedure, but it could certainly incent people to take such procedures seriously, giving a tax credit or making it somehow advantageous if they were to carry it out. And what we could have as well are people want to have healthy babies. So those who could afford to do such things would certainly do it because they want to have the healthiest sort of child. They don't want to have it be plagued with disease and so on. So it's like I think it's a bit more complicated than saying whether a government is just going to impose it, and whether we'll just evolve to start adopting such behavior.
Right, just a quick comment. I think from the purely biological point of view, in some sense, we are trying to fight against the natural selection. As you said, maybe 2,000 years ago, people are supposed to live just in their 20s, 30s. In that sense, you filter out those bad genes. But now we are trying to find all kinds of ways to extend the lifespan, in some sense, to foster the density of those bad genes in the population. Of course, I'm not saying government should do something, but probably we need to think a little bit more on that.
Yeah, so this is what I think this is my central point, which is that we can't have you and biological solutions over here, and us and social realities over here. We need the science leadership community to be engaged in the public policy debate, because they are not isolated, separated items. We are social organisms, and we need to figure out what this biological science, the developments in these sciences, means for us as a society, and that's the connection I'm worried isn't being made at the moment.
Okay, so let's do 2 more questions over here.
Hi, so thank you for your wonderful talk. It sounded like one of the NHS's priorities was to introduce more APIs that allow sharing of your data with third parties. And that's awesome in that it's very empowering to the consumer, right? And it's probably, like you said, the most realistic way for healthcare technology to keep pace with consumer technology. But 2 things come to mind. Like over the last decade of the rise of social networks and large internet companies, first of all, that consumers are not, in general, that good at understanding the ramifications of sharing data. For instance, like all the social network accounts that can be linked together and all the different sources of data that Google probably has on me that I don't even know about. And then secondly, that companies are very good at incentivizing you to share more data, right? Because take on Dropbox, they want you to link other accounts so that you get more space and so on. So I'm just curious what your viewpoint is on this future where data that is submitted from a patient to the NHS, under the guise of this is my healthcare, this is data that is just for the doctor to help me, is suddenly being shared with companies that have all kinds of other motives in mind, like selling ads if you're Google or whatever it is that Facebook wants to do with all of our information, and what that future will look like.
Yeah, so the basis, so let's be absolutely clear. So if you want to share your data with some cool app that's going to tell you what your shopping order should be based on your medical profile in that week's clinical record, then and you need to understand what you're consenting to doing. At the moment, we have this very, very flawed approach in retail environments, online retail environments, to click and consent. It's a completely inappropriate model for healthcare. And actually, we haven't yet developed properly a model of consent that I think works for healthcare. So one of the first things we're now looking at, this isn't consent, of course, to a surgical procedure or a genomic assay. This is the kind of consent that does express to you what the implications of your sharing of your medical data are with different third parties. So one of the things we're doing is developing an approach to that as we begin to, in a very alpha way, develop the offer around online record access. We're also looking very deeply at what consent looks like in a genomic world. And again, we can't use historic precedents of ways in which people have consented to surgical procedures or whatever, medical procedures, to guide us much, because they don't really work. So there's an awful lot of work going on at the moment about consent. In the end, the doctor's duty of care in our system overrides somebody's rights to access their own data. And there will be circumstances in which somebody might be harmed by accessing their own data. And we can think of, the abused woman being forced by her husband or whatever to reveal her medical records. We can think of circumstances which are, unfortunately, relatively common, in which a GP might decide that actually it's just not safe for somebody to have access to their own data. That still remains as the overriding. It will be the GP's decision. So we're heading into territory, like most of this, which is uncharted. It's going to be pretty tricky. We're going to take it slowly and cautiously, because whilst the public kind of want all this stuff, you're right, there are some things people haven't really thought about. And one is, well, what happens when I give my data to some really terrible app? And what I don't want to do, what we don't want to do is restrict the market by having some terrible curation process for apps and digital tools, which means that no garage developer can ever play in it. But we're going to have to do something more than the App Store does, which has currently got thousands of completely dangerous health apps that will tell you you've got a mole when you haven't, that's cancerous. You know, I mean, so we have to be. So we've set up a whole program for looking at what we call endorsement. How can we, in a way, leverage the trust in the NHS brand to start helping people have confidence in their selection of different digital tools? But it's a really difficult challenge because we don't want to create a kind of devices infrastructure which will kill off innovation. So it's tricky.
Okay, final question to Roman.
Hello, hi Tim. Thanks for the talk. It's very interesting to have a view from the outside of the immediate area where I'm working in. So the question I have touches on many other issues that people have raised. Do we need a revolution, or can we get away with the evolution of existing system?
Yeah.
Because, I mean, it is a lot more difficult to sell the need for revolution.
Yeah.
Because I'm very cautious about revolutions. History
happens.
Yeah. So, is there a way we can actually evolve quick enough to, in a way where we can foreshadow many of the problems which may arise in the future?
Yeah, I'm really glad you asked that question, because the answer is I believe we can. So this is definitely not about revolution. It's about recognizing the dysfunction that could occur and putting in place the preconditions for an orderly transition to a very different kind of world where we are suddenly in touch with our data in a way that has never happened before, and we don't end up making that a miserable experience for mankind. And instead we make that a basis for unleashing an extraordinary new potential. And I think we can do that evolutionarily if we get onto it now, if we start asking ourselves the key questions now and start building a kind of a thought program around what all these different things mean, and we work with partners around the world and in different academic and clinical contexts. So I think it's about just building a kind of social movement around the question, and I think we can manage an evolutionary transition. I think revolution would be unthinkable, and it would be a massive failure if that's what actually happened.
Thank you very much.
So I think before we thank Tim one last time, I wanted to highlight how we all should maybe be a little embarrassed about Frank Rosenblatt, because as I was looking on Wikipedia, he was born and raised in New Rochelle, went to the Bronx High School of Science, and Cornell for his undergrad and graduate work. So it took the UK guy to inform us. But yeah, thanks a lot, Tim. It was fantastic.